Getting started.
Oh, okay.
And here we go. This is Andy Revkin. I run the new center, the new initiative for communication and sustainability at Columbia University's Earth Institute. And our goal is to make information matter. I've spent 35 years as a journalist writing about issues like climate change, disease, earthquake risk, and a host of other large-scale threats to human progress. And we've made a lot of progress on some, but on other kinds of things, we seem to be stuck in what in 2008 on my blog, when I was at the New York Times, I called this the blah, 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 bang syndrome. There are things we talk about that remain big risks. And here's a perfect example with the coronavirus disease 2019, COVID-19. This was not a surprise. This is an inevitability in a way. And there's been warnings for years about the way things are flowing in the planet between species and humans, other species and humans. And well, we'll be hearing about the microbiology of this, and we'll be hearing about the impact in India. Mainly, the goal of this show today is to talk about India and what can be done to blunt the impact. You know, here in the United States, we're in lockdown mode here in my little village in the Hudson River Valley, 50 miles north of the New York City. Everyone's shutting down. You can see it's happening. Restaurants can only serve food as a takeout. And India has 1.3 billion people. And as I just tweeted, the testing rate is 5 per million. In the United States, we were appalled when I was reporting the other day. It's about 25 tests per million people. South Korea is 4,000. So, you know, it's really hard to get a grasp on what's happening. And that's why I reached out through Twitter, through another journalist, to Priyanka Pulla, who's a really great health reporter in India, and to Gagandeep Kang, who's a microbiologist with a really multifaceted approach to public health, not just a laboratory scientist. And so I thought we would have a conversation today about what's going on. Maybe we'd start with some of the basic science. Gagandeep, you had posted today or yesterday a tweet that I retweeted about a very, very troubling case of a man who had come back from Europe and had spread the infection unknowingly, and his mother passed away. And I think they've counted 813 people he has known to have contacted. That's a pretty rough situation. If you amplify that, there's 142 cases identified as of today. But what's your sense of what you're seeing here scientifically?
So if we look at what's happening in terms of spread, this particular person was very interesting for the duration of time that he was asymptomatic, and he was able to be in contact with hundreds of other people as he went to work. Now, while he did spread his infection, we know definitely to his mother, it is possible that he also spread it to some of the 800 plus contacts that we had. There's still some of them in the incubation period, and we'll find out the extent of transmission if they become symptomatic. If they are mildly symptomatic, if they don't present to healthcare, we might never know. So this is what the disease looks like. I think COVID-19 is so much more dangerous because people who are well, people who are professionals, young people who move around a lot, interact with people a lot, are the ones who are spreading the disease. So understanding the extent to which people are transmitting requires for us to do way more follow-up and testing than we are doing. We're doing reasonably well with follow-up of imported cases and their contacts, but there is always the piece about what we don't know and what we are not testing at the moment, and that's the bit that I'm really worried about.
And what's your sense of the public a perception of what's happening? Are people afraid to go to doctors, or is there a comfort level with making sure that people know if you're not feeling well, or are people unaware completely? What's the situation? Priyanka, maybe you could weigh in on that.
I think Dr. Kang would be the better person.
Okay,
but,
sure.
I'm sure she can tell you about H1N1, which I think is one reason why government officials are so wary about creating panic, which is why I see a little bit of playing down of COVID-19 associated deaths. But, I can talk about public perception separately, but there is a big worry amongst government officials about not creating panic so that the testing infrastructure doesn't get overwhelmed. But I think Dr. Kang would be the better person to talk about the H1N1
Yeah,
pandemic.
that would be great.
experience.
Yeah, sort of put this in the context of what happened at that point.
So I think actually for a lot of H1N1, the buildup was very similar to what we've seen here. Not on the same scale because we didn't have the same penetration of social media as we do. There was a fair amount of people worrying, people saying, oh, it's going to get imported. And then finally, when we saw the first case in India, it was actually not an importation. It was somebody who had no travel history. So there had been community transmission, and everything that we had done before had not picked it up. In this case, we got off the ground with initiating testing in travelers a little bit earlier than we did for H1N1. But in terms of how we have gone beyond that for identifying cases, deciding whom and how much to test, and who will do the testing, we seem to have approached it a little bit differently. For H1N1, there was an early engagement with the private sector. There was testing in private laboratories. There was preparation of private facilities at a very early stage. In this case, what we've seen is limiting the testing to government facilities and doing very limited testing of only people who have come in, become symptomatic, and their contacts. As of day before yesterday, there is going to be testing in hospitals as well, but it's only going to be symptomatic healthcare workers who have looked after people with severe respiratory disease. Once again, so there is a difference in how we have responded. I completely agree with the government that we really don't want panic. We don't want everybody overwhelming the testing system. We don't want, in a situation where you have limited tests, you don't want everybody with mild disease wanting to get tested.
Sure.
But I think beyond that, we need to apply epidemiological principles to a more sensible approach to testing.
And how about the preparations generally for the just based on the epidemiological, the past and population patterns, you kind of know what's coming to a certain extent. So how is the system being geared up?
This has been declared a national disaster. And the National Disaster Management Authority is involved in the preparations. They're working with the Ministry of Health. So while I don't know the extent of the preparations, I know that there are high-level meetings at the government on a regular basis. And certainly political leadership, both the Prime Minister and the Health Minister, are trying to calm people down and try to offer good advice on what needs to be done.
And Dr. Kang, could you just give a little background on yourself for listeners who are just joining us and aren't familiar with your experience?
Sure. Yeah, I'm a microbiologist, a medically trained microbiologist. I mainly do public health now. I'm very interested in vaccines. I've worked on outbreaks for cholera and typhoid. I work on rotavirus, so infections in children. and I'm vice chair of the board of CEPI, which is the Coalition for Epidemic Preparedness Innovations, and I chair the Regional Immunization Technical Advisory Group for the WHO CRO region.
And what do you think? Right now, there is, I think just today, the US announced with a private partner, they're starting human tests on a vaccine. And I know the media have been very careful to say this could be easily a year or 18 months before that could be something that's distributed and safely, certified for use. I guess that's always a challenge here. It must be so frustrating to see the kind of innate lag time we face in dealing with these epidemics once they're out and around.
So I think in terms of vaccines, what we've seen in this particular case is a more rapid response with vaccines than we've ever had before for an unknown pathogen. But I also think that we need to be very careful about projecting vaccines in the early stage of an epidemic, because the vaccines are not going to be ready for a year or more. Even with having vaccine candidates from multiple companies today, many of them we know are going to fail. And yet, when the public hears that there is a vaccine candidate, they think a solution is around the corner. It's not.
Yeah. So let's shift to the journalist perspective, and we'll be taking some questions from listeners too, viewers, listeners. Priyanka Pulla, how you've been covering this pretty aggressively now. You're starting to on The Wire and elsewhere, and you have covered health issues like this before. So, can you give a sense from whether you feel the journalism community there is remotely prepared for what's happening? I can tell you here, it's a rough. It's rough everywhere. So, what's your sense? And everyone, again, Priyanka Pulla is a health journalist. You're based in Bengaluru?
Yeah, I'm based in Bangalore.
Yeah.
Well, I think it's important to get information regularly, but as somebody based in Bangalore, I find that it's a little harder to get it from Delhi. And I also know reporters, like I was speaking to a reporter yesterday who was here from the US, and she's here to cover the outbreak. I think information is somewhat tightly controlled in terms of just asking hospitals how their preparation levels are. And I do understand that they're all under a whole lot of pressure. So you don't want journalists calling them up. But I do see a very centralized way of disseminating things, which could have been different. So, yeah, and I actually wanted to add to something. In fact, a question for Dr. Kang.
Yeah, sure.
Yeah. So the ICMR's testing strategy, where they've looked at, I think they've tested 500 community-acquired cases of severe acute respiratory infection so far. And I believe they're going to be testing 20 samples per week. That's the community-acquired testing strategy, which is people who have no travel history and no contacts either. And I think so far they've only tested 500 samples. And they say that out of these 20 labs where they have tested these 500 samples, there's absolutely no spike in severe acute respiratory infection cases so far. In fact, they're not even able to get 20 samples. But this has happened for 2 weeks so far. So I was wondering, would you not see a spike in, because that seems to be giving ICMR a lot of confidence that there's no community transmission. Would you not see a spike in acute respiratory infection till now? And, do you think the confidence is warranted? Sorry, I know I'm supposed to answer questions, but
No, this is a conversation. This is not just me asking questions.
Yeah, so one of the things that you must remember about the vaccine the virus research and diagnostic laboratories that are part of the network is many of them, their denominator data is the number of tests that they are doing. So I'm not really sure how well it relates to the number of patients who come into the hospitals for that. So it may have changed over time, but a lot of it is around how many samples are actually being sent to the lab for testing, not necessarily correlating with the numbers of patients that they had coming into a facility. So I'd really like to see large facilities who track data over time. And as you know, we don't have a lot of those by reason for admission.
Okay, so you're saying there are respiratory infection cases admitted, but samples are not being taken from them.
I don't know that
Okay,
because
sure.
I don't have a patient denominator. Usually when we've seen VRDL data before, we've just seen the numbers of tests ordered and the numbers of positives from those tests. Now, if that links back to a really robust denominator of patients, then there is not a spike. If it doesn't link back, which was the case when I last saw that data, then it doesn't tell you that much about it. I'd also like to point out that with respiratory infections, especially when you don't have the classical seasonality that is seen with influenza in more temperate climates, you are going to have respiratory infections around the year, and they are going to be multiple causes. So that's another thing that we need to do. We'd like to look at etiologies in the respiratory specimens that come in. And coronavirus at any time is going to be only a proportion of those etiologies. If you look at the Seattle Flu Network, for example, it's not like coronavirus is number one, if I don't have that wrong, right? The other thing that relates to this is, one, no denominators. Two, you have to see what proportion is coronavirus. And the third is, when you have a new introduction, it's going to be spotty as community transmission is set up. So where are the 20 labs located? And does it make sense to have those 20 labs versus another set of 20 labs? I really don't know. I can't comment, but based on just saying there are 500 samples, I could think about better ways of doing this.
Yeah, No, I'm just saying for Andrew, but based on the 500 negative samples, the Indian Council of Medical Research is saying no community transmission, and therefore we will not test anybody who's either not had a travel history or has a contact with them. But that's the one data point which they're relying on very heavily, which is confusing for a lot of people.
Yeah. Now, I just wanted to bring up the New York Times did a pretty comprehensive story on the situation in India that ran yesterday. Today here, yesterday there. And there was some pretty impressive sections showing the use of mapping of activity, where people are moving. I think it was down here in Kerala in the south. The authorities use GPS technology, closed circuit TV, and mobile phone records to trace the movements of an Indian family to try to kind of track things forward. And several sections here had implied a pretty decent capacity to ride herd on the things that are known so far. Do you have a sense of that level of preparedness reflected there as being what you perceive too? Or is this, I want to be sure, there's that low test rate, like 5 per million. And some people could get the impression India is facing a tsunami here. So maybe just stepping back and getting a characterization from both of you of how you think the situation is right now in terms of overall preparedness and being able to keep track as these cases come forward more and more.
So the example you're talking about is from Kerala, and There are, as Dr. Kang will tell you, there are massive statewide differences in how stuff like contact tracing or even airport screening happens. So there's one news report in Economic Times about, airport screening has been around for a while, but there are a lot of instances of people who walk through without going to thermal scanning, and airport screening was voluntary so far, in the sense that if you had traveled, you had to fill up a form and then you had to present at a counter at the airport if you believed you were if you believed you were at risk of contracting, and there are lots of gaps in that. So it's highly possible that both airport screening and contact tracing have been very, very variable across the states. The Kerala example, I don't think is representative at all for the rest of the country. And when you're talking about 800 contacts or so, I don't know how you can track all of them, no matter how hard you try. But again, to Dr. Kang, she's probably the better person, definitely the better person to talk about this.
And Dr. Kang,
I think Kerala shows that good work can be done. But as Priyanka said, there is a lot of variability across states, and it's encouraging to me that a lot of states have reached out to Kerala to see what lessons they can learn from that. So that means that at least in terms of being able to trace people, we will do a better job than we have ever done before. Whether that will be sufficient or not, I think only time is going to tell. Usually I'm very optimistic, this time somewhat less so.
And one question, do you see this as really primarily an urban risk right now? Is this going to inevitably, I assume it will inevitably spread pretty widely. That's the pattern pretty much everywhere. But is there a way to maintain it as an urban problem, or is it just too much mobility to hope for that?
So both density of population and the amount of movement are issues that we need to worry about. If you think about social distancing and when we want to implement that, what worries me is then we are going to see a spread in community clusters. Right now, I think we would start to see disease more in urban areas, mainly because that's where importations are going to happen, and also because they are more densely populated. But because we have a fair amount of urban-rural migration, you are going to see seeding coming into rural areas and then possibly transmission there. Right now, we have no idea if that's playing out because we are not doing the testing that would allow us to evaluate what's going on.
Right. That issue you brought up a few minutes ago related to the other illnesses that are still so common is here too, the flu and the rhinovirus. My brother is a physician, and he had come back from Europe a few weeks ago with a bad viral respiratory infection. He ended up, it took him days and days until he could get tested. He went to Greenwich, Connecticut from New Haven, where he has a position at Yale. And it took 4 days for the test to come back, and it was negative. It was rhinovirus, and he was tested positive for rhinovirus negative. So there's definitely, well, here, it's the flu season. There, at this time of year, I assume you have other issues as well. It makes it particularly hard.
Now, I just wanted to talk about India's health infrastructure as such, and again, as a question posed to Dr. Kang.
Absolutely.
So for my reporting for my other story, we were looking at, so we know that the case fatality rate in Italy is so high because one-fourth of its population was elderly. And in India, I think in the 65 plus age group, we have 65 million people. That's much more than Italy. We have 72 million people with diabetes. And we have some 54 million people with heart disease. And in terms of beds infrastructure, we have 1.3 beds per 1,000 people. as opposed to what WHO recommends as 3.5. Critical care beds, far, far lesser.
Right.
Infection control, extremely poor for the vast majority of hospitals. And that's going to be a big issue, as Dr. Kang spoke about. A lot of people have been talking about even if 1% of this population at risk, which is the elderly people or diabetics, or get infected, our hospitals are going to be completely overwhelmed. So Dr. Kang, who's does this for a living, who's worked in a hospital, how do you think this is going to play out if 1% of the people get infected?
That's a hard question to answer. I can say that even with H1N1, which was relatively milder, there was a lot of pressure on hospitals because we did have the more moderate and severe end of the spectrum coming into the hospitals. And it was challenging to handle. So I don't anticipate that this is going to be manageable or easy if we come up with the even 1% that you calculated. If it gets harder than that, I know there is a fair amount of effort going into preparedness. I know that governments are placing orders for ventilators, trying to find manufacturers. But the extent of that preparedness will become evident when the system is tested.
Right. And when I was tweeting this, as some doctors responded to me on Twitter, it's not just about having ventilators, but it's also having the personnel to man those ventilators, right. Trained people to maintain them. And we have pretty high rates of ventilator-associated pneumonia. And many of these hospitals where they're being treated are not accredited. They don't have very good infection. So that the secondary infections, I think, also would be a cause of worry.
Yeah, that brings up a point that I hadn't thought about until now. In China, there was that issue with men there have so much smoking. Only 2 or 3% of Chinese women smoke, but men, it's like half. And so you have these predispositions. I wrote a couple of years ago pretty extensively about the cooking pollution in India. The background rate of exposure to particulate pollution is so high, both urban and then in rural settings and households. That gives you a very bad kind of a background risk factor, I guess, as well. So this sounds pretty unnerving. It sounds as big as India. You know what I mean? It's a wonderful country, and it's part of me is pretty unnerved, having spent only a little time there and seen both big cities and the rural areas where I was reporting on cooking pollution. And you have some things we don't have in the United States, like the ASHAs, the accredited social health workers who are monitoring in village settings. It's fantastic. But as you were saying a minute ago, the challenge with severe respiratory problems gets, it's the hospitalization part. And I personally, it makes me pretty unnerved. There's a question from Dinesh Thakur, which I'll post here. I don't know if you can see the questions when I post them on the screen. Do you see?
Yes, I can. So I think ICMR is reporting what it has tested. And while ICMR in its interview yesterday did delineate what their strategy is looking like, which is to continue to use their ILI network and only think about expansion after something in the ILI network comes back positive, if I've understood correctly. I would really advise that we need wider testing. 500 random tests being negative is reassuring on one level, but I guess I'm feeling so insecure that I'd like more reassurance.
I'm not sure if we went through whether there's sufficient tests available, actual test capacity.
So Priyanka, if I can take that, I think one of the things to remember is that when you establish PCR assays, there are multiple kinds of PCR assays. There is, of course, the real-time PCR assay, where the probes are, I think, being imported from Germany. The primers are being made in India, and the rest of the reagents are available in India. But you could be thinking about alternative diagnostic strategies. You could do a routine, what we call a block-based PCR instead of real-time. And for that, reagents would be readily available in the country. It just takes a little bit longer to do, so you wouldn't have the equally rapid turnaround times. But at least then there would not be a limitation on the capacity to test, because there are lots of trained people and PCR machines. The ICMR has also said that right now, testing capacity is not a limitation, and they are basing that on their own laboratory network being insufficiently utilized. But if we were to change what comes into the network by expanding the case definitions of who should be tested, then we could very quickly use up the ICMR capacity as well as the additional government laboratories that have been notified for testing.
It's interesting. Here's another question. Hold on. This technology is pretty good, pretty cool. Really appreciate your both being willing to do this at first thing in the morning. There's lots going on. We can, go for another, 15 or 20 minutes, depending on your what you have to do now. And there's a question here. The number of tests varies hugely by state. Again, this gets at the scope and geography of India. There's no clear, simple way to have a one picture, I assume. That's just as true for the United States.
No, I think a sampling strategy has to be defined by population and I think by where you expect seeding to take place. I'm not sure whether the testing strategy that ICMR and the Ministry of Health is based on that, but we've been told that there is one.
Okay. Hold on. The other thing that came up in a chat I did 2 days ago with a couple of people who are involved with national security planning and a big strategy in the United States related to how we define security, really. And it used to be mostly having a big army and being vigilant and having a good State Department. Some of that's been eroded lately, but there's a growing argument for internal sustainability to be a critical component of, in this century, of security. That if we're in a world that's hyper connected now, so that a microbe, a novel mutation in a China wildlife can now become a global threat. There was several recent reports saying that this is the age of pandemics. Essentially, we've created a hyper-connected world. We have in places like China, there's so many experiments being biological, essentially intersections that are creating this potential for rapid spread. In sub-Saharan Africa, some places as well. When you think about India in that same way, do you feel that there are any fundamental changes that need to be made to the relationship of public health and security, and how a nation plans to be robust in the face of these kinds of threats? Or is there a discussion there yet about those kinds of questions?
Dr. Kang first.
So we'll take the security question and the self-reliance one. And I think there is a sense that, it's time that we built in-country capacity. And if you look at India, it's one of the countries that invested, one of the developing countries that invested in science and technology very early on, and built a system where you had institutes that can do really high quality work. Now, many of them have been focused on basic science to a large extent, and with our current government, they've been asked to move more towards looking at translation and building capacity for products that enable us to be self-sufficient in many senses for drugs, for vaccines, and for biologicals. So in terms of what India has already done, we've built a certain amount of capacity. It is not necessarily the cutting edge capacity for novel products that can be made rapidly, but certainly in terms of manufacturing and process technologies, our industry has done a really good job. Now, if we think about linking academia and industry together, I think we have huge opportunities to solve problems for ourselves as well as be available to do things that can benefit the rest of the world. So that's, I think, very, very positive about what the government and the country have been doing together. There are always issues, and I'll hand off to Priyanka.
For the issues.
Surveillance systems can be improved hugely, and this is information I get from Dr. Kang. For example, syndromes like encephalitis, fever, acute flaccid paralysis, which was basically once upon a time it was polio, and there are so many other causes right now. And I was actually speaking to Dr. Kang about this for a story earlier. We have very large number of cases. Like I think 2 years ago we had 30,000 cases in the country, the causes for which were not known, of acute flaccid paralysis. Could be anything, whether enterovirus. And we're really not going into these causes because that would be a logistically, infrastructurally very challenging system, because you'd have to test every, depending on how severe the case is, you would have to have access to microbiological testing, etc. But what I'm saying is there are a lot of these syndromes for which we don't really know what the causes are. And that's number one. Number two, just looking at potential of spillover for zoonotic diseases. I'm not sure how much research we do into that, because there have been a couple of groups which are looking into that recently, but they have been asked to stop doing their research for various reasons. I'm just saying both surveillance and research into zoonotic illnesses is surely not widespread enough, and I'm sure Dr. Kang will agree with me there. So.
I think there's always more that can be done. And I think in terms of microbiology capacity, we do have the ability to build out better surveillance systems. And I hope that if anything good comes out of outbreaks, it is the establishment of better surveillance.
Speaking of surveillance, different scale, a need was described in another discussion I had, a glaring need for more active, professionalized work and communication around emerging disease risk. I was told the World Health Organization pretty much has one person for social media related to these issues. And Laurie Garrett, who's a longtime reporter, been focused since the 1990s on epidemic risk. Actually, what am I saying? Since the 70s, she was reporting, in the early days of AIDS, and on. She wrote a piece in The Lancet that came out a few days ago on the need for really a big boost in spending and sort of professionalizing how to monitor social media, to tamp down rumors, to actively be involved in taking the temperature of the online information system. this relates to both Priyanka's work as a journalist and your work in public health. In India, I know here for sure there are still big gaps. Rumors spread so fast, and as has long been known, the truth. I think Mark Twain, an American writer, said, "A lie gets around the world while the truth is still tying its shoes in the morning." Is that, how important does that feel in India? Like to take the temperature of what is being said in the media and social media, and having that be part of the public health plan?
So I'll give you a very specific example. In this outbreak, India currently believes they are in the local transmission stage, right? Which is like most cases are imported cases, and then there are contacts. There are no cases which cannot be linked to travel history. I think that's a very important piece of information. But since this outbreak happened, we have gotten so many conflicting messages from the health ministry. So while the top officials say we are in local transmission, there have been anonymous sources from the health ministry saying there's community transmission. There have been sources on the record saying they're community transmission. And then they go back and say, oh, no, we meant local transmission. So maybe it's that they do not know the definition, but this kind of thing is really, it can completely throw journalists off, right? We are completely relying on you. What I'm saying is this kind of mixed messaging is like, it's really, really bothersome for journalists. And I personally increasingly think that 50% of public health is communication, because in public health, you want people also to do something. It's not just the government and the doctors, but you want interventions and action from people. And so it's not just about building infrastructure and surveillance. It's about telling people what you're doing in very, very precise terms. We're not there yet. I can give you like so many different examples of confusing messaging from the Indian government, which we could certainly do without.
Although I will say, I think we have you beat there, given what the Trump administration has been doing through these last few months. The level of outright deceptive, untruths, lies, whatever you want to call them, is just there's been a flood of it, and then this slowly walked back, and it's created this reverberating effect, where in polling, just a couple of days ago, a poll showed that there was rising within Republicans, people who support Trump. There was rising doubt about the severity and importance of what's happening between like mid-February and now. And that just blows my mind. It shows you how, at least studies that have been done here by sociologists, behavioral scientists, show that the truth is secondary in how people shape their worldviews. There's something called cultural cognition, where you look at the same numbers and you come away with a completely different interpretation depending on your political orientation or your cultural background. And that's the United States. So maybe you might have it less badly than we have it. I'm not sure. But Dr. Kang, I don't know what your perception is there too on the importance of somehow getting a hold of that.
So I think in terms of misinformation being spread, that has been a concern for a lot of public health issues in India recently. There are all kinds of solutions proposed that are, on one hand, either pseudoscience, or on the other, based on a cultural perception of what is good. So Ayurveda and herbal medicines have all of the solutions, for example. I think that we have a lot to learn from traditional medicine, but I think that we should be holding traditional medicine to the same standards that we hold what we call modern medicine. You should be testing interventions as rigorously before you offer anything as a solution or a treatment. In terms of, I think I agree with Priyanka on what she said about communication. There is a lot that people can do And if we are communicating accurate evidence-based information to them, that will be helpful. The cultural constructs and people deciding based on their worldview what they are going to choose to believe or not, that I think is a global phenomenon, and we are not immune to that.
No. There's a listener, viewer who just asked if this website, which I'm showing now, is a reliable one. covidout.in. Is this something you all are familiar with?
I've been looking at that website for the last couple of days, and they are tracking and updating the information that is available.
Just one point to add to what Dr. Kang said about us not being immune to the cultural aspect of miscommunication. But the trouble is right now, it's the Indian government who is just pushing some of these narratives and pseudoscience. I mean, one arm of the Indian government, not the health ministry, but the Ayurveda ministry. And that is extremely troubling. And that's definitely a recent phenomenon.
Is that being written about in the media, or how does that play out in the sphere of news?
No, it's heavily criticized, and then sometimes there's a walk back. Recently, soon after COVID happened, I think the Telangana state government was distributing homeopathy as a preventive for COVID, and I think the Ayush ministry, which is a central ministry, put out a press release recommending Ayurvedic, one of the streams of medicine, and that was heavily criticized on Twitter. And then soon after, the health ministry came in and sort of broadly said, don't listen to anybody else, listen to us. But that is basically two ministries of the government saying two different things.
That sounds pretty challenging.
It's challenging, but I think also, the ministries have to come up with some kind of solution. And if Ayush thought it had a solution, it should probably have spoken to the Ministry of Health. It clearly didn't.
Interesting.
And I think the problem really is, where do you find credible sources within government? I'm actually very encouraged by the fact that ICMR is now having regular meetings with the media. It was previously difficult to access a group of scientists within government. So the fact that they've had 2 meetings in the last week, I hope that is something that they will keep up, and that we'll see more and more information emerging.
I completely agree. The press conference which ICMR had yesterday was fantastic to be able to tune in from outside. I feel they can do more, but I completely agree that it's better now.
On that front, there was another question from a watcher. Oh, that's not the one. Hold on. Where is it here? Here it is. Sorry. What is the challenge given the diversity of languages in the country? How effectively does Dr. Kang think we're doing in getting the message out in that context? I guess that gets to the regional and question too.
So we have in the north messages in Hindi, in the south messages in Tamil. Priyanka, are there messages in Kannada as well?
I believe so. I can't hear it, but there are people who are, I don't know if it's a particular network I'm using, but I'm told in Bangalore, yes, there are Kannada messages also.
This time, I think the government has done a better job of communications. They've gotten out there much earlier. They have had newspapers with advertisements, with helpline numbers, with telling people what needs to be done. So in terms of communications, I think we are doing a way better job than we've done before. Could it be better? Yes, everything could always be better. But you have to give some credit where credit is due.
No, absolutely. So every phone call, I don't know, if Andrew and the readers, the listeners know, but every phone call, every time you make a call, you get a message talking about COVID-19 and the precautions you're supposed to take, which I think was an excellent move. Because I've been asking some people who know, do you know, the amount of awareness is really high. Like, I had some people, service providers here, and I was saying, why don't you wash your hands? They said, oh, for coronavirus. So everybody seems to know because of that phone call. I think that was a fantastic strategy.
That actually gets to another. Oh, sorry, Dr.
Andy, I'm really sorry, but I'm going to have to drop off now.
No, that's fine. You've been very generous with your time, and this is an incredibly important time for India. So get back to work. We greatly appreciate having you here. I might check back with you in a few weeks if we can. And
sure.
Good luck with all your work, Dr. Kang.
Yeah.
Thank you very much.
Thanks so much.
Yeah, and Priyanka too. You as well.
Yeah.
There was. Let's do this again.
Yes, sounds good. Thanks for having me on this.
If you don't mind, there is this one last question maybe you could weigh in on. And this gets to what Dr. Kang was saying too. It's about the spirit of the country. I got a sense when I was in India. I learned also about things like the Ujjwala program for LPG. The middle class giving up its subsidy for the sake of getting clean cooking fuel to the poor. That seemed to push forward in ways that implied a significant generosity of spirit. And I don't know what's your sense as this plays out in the coming weeks. It's going to get pretty hard, like it is here now. Is India in a situation where you've had so much turmoil over religion? Do you have a sense of confidence in one way or the other whether this will go toward a communitarian outcome or not?
So I think it's really easy to take precautions and maintain social distancing if you're in a privileged position.
Right.
And so I think a lot depends on what you're faced with, because this was highlighted to me when I read about the case of the first person who died due to COVID-19 in India. This was a person in Karnataka. And after he passed away, this was a 76-year-old man, the government put out a press release saying that he died due to comorbidities, which is really troubling phrasing. But they kept repeating that he had gone from one hospital to another, despite being told not to. So basically, he was admitted to one hospital, and then the family said, no, we're not going to keep him there. We'll take him to another hospital. And they said, we're not going to keep him there. We'll take him to another hospital. So against medical advice. And the government said it's because of this that, he basically violated all precautions, and therefore, look what happened. And then eventually another side of the story emerged, which is that some of these hospitals actually turned him away. And he actually passed away on the road without any medical help because these hospitals were not willing to keep him, and because they did not have isolation facilities. So, when you talk about social responsibility, taking medical advice, it has to be reciprocal. The government and the medical system also has to respond by telling you, by helping you out when you're in a difficult situation. The other example is people in quarantine. People in quarantine and people being isolated in various hospitals across India, and they have shared pictures of the kind of hygiene levels in hospitals, toilets which are overflowing, etc.
Right.
And there are cases of people running away from such facilities. And of course, you're inclined to blame them, and you say, "Oh, you don't have a sense of social responsibility." There'll always be some bad eggs who only care about themselves, but you also need to have a system that inspires confidence. So I think it's really difficult to put all the blame and responsibility on individuals when the whole system is not working. Yeah.
And one last question for you. When I interviewed Laurie Garrett, the journalist here who's had so much experience with epidemics, she was sort of offering a warning, a caution to journalists diving into this one to harbor your own energy and to be generous to yourself, because this is really tough journalism. She's also done war reporting. She was reported on the first Persian Gulf War. She feels that this is harder because the consequences of the reporting are so important. And it, unlike with war reporting or what I've done with climate change reporting, she says the stress factor and not wanting to get anything wrong can really weigh on you. I don't know if you're feeling that yet, or if you've felt it in the past, but does that feel like something the people who are going to be reporting on this need to be concerned and think about?
So I tend to write features more often. I'm not like a daily newsroom reporter, but I can imagine how much stress they must be feeling because, like I said, if there's confused communication from the health ministry and there are all this new terminology coming out, I think the responsibility on daily reporters is huge. Yeah. I can't imagine how it can't be stressful. Just the pressure to be precise. There are mistakes happening. I mean, I can see so many issues with the reporting, and it's tough. It's definitely going to be really tough. And maybe and you have to get the news out immediately, but maybe if it helps, just step back a little and take some time to analyze and publish a little later. I think that's also okay.
Yeah, it's true. Know when not to publish.
Yeah,
it's important. And social media, I think, well, all journalists are grappling with the reality that social media is a bigger and bigger part of what the work. And that can be stressful too.
Yeah, absolutely. I mean, I have been using the social media predominantly. So far, so good.
All right, good. Well, hang in there. This is going to be a long road, I'm afraid, and a long century. We're into some uncharted territory here in a world that's already heading toward 9.5 billion people by mid-century, with so much connectivity, so much complexity, rapid change, resilience, and adaptability, and really a strong focus on communication has to be part of how we go forward. And I really appreciate your time.
Thank you so much. It was really great talking to you, Andrew.
And have a good day.
Same to you.
All right. Take care.
Yeah.
This is Andy Revkin signing off.